Hi, everyone. I'm Bill Ikest, Regional Vice President of Business Development at Keybridge Medical Revenue Care. I'm joined today by two very special guests and good friends. I've got Gail Scarboro-Hritz, founder and managing partner at Hritz Management Services, and Day Egusquiza, president of AR Systems Incorporated. These ladies will be presenting together at the upcoming HFMA Region 5 Southeastern Summit in Greenville, South Carolina, February 18th to the 20th. We thought it would be really fun and good to take a quick sneak peek at their session and get to know these two amazing revenue cycle leaders. The title of their session is going to be Punishing Denials While Going for Gold. So, ladies, welcome.
Thank you.
Thank you.
Tell folks a little bit about yourselves, if you would, real quick, and just include in there what your first job in healthcare was.
You want to go first?
I'll be happy to go first. I'm happy to be here doing this with you two folks today. And my first job was as a float in an acute care hospital in Dublin, Georgia. My first healthcare job. I had had other kinds of jobs before that. And little did I know what that would lead to in my life, because I learned how to do everything from answer the switchboard, which, by the way, was a plug-in one. Had to plug in cords and admit patients, collect from patients, do all of the things that we continue to need to do. In those days, we didn't have prior authorization when I started. We assumed that things would be paid for if the doctor said they were necessary. So a lot has happened since then. And now I have my own firm after having served as a chief revenue cycle officer in several very nice organizations: University of Mississippi, Medical University of South Carolina, worked at the Cleveland Clinic in a large leadership role. So, and currently I'm working with University of Florida, and I work with a number of our friends in various companies that help, business partners that help our providers and help us do our jobs. I think that's it for me. How about you, Dave?
Day, how about you?
Well, let me see. Day Egusquiza, president of AR Systems and founder of our foundation, the Patient Financial Navigator Foundation, which is part of my personal Pay It Forward, so that I am continuing to offer education through the foundation and also helping people during Medicare time so that we can help facilitate that education, MA, Medicare Advantage, or traditional. Been doing this since 1980, and I started with DRGs. So it's like I remember when they hired me for my position in the hospital, they said, well, we're going to hire you for this office manager position, but we don't expect you to have a job because DRGs are going to eliminate the need for business offices. I will never forget them hiring me and saying that. I'm like, okay, I guess I'll take this job, which of course turned out to be the career of a lifetime for me. I've worked in my 200-bed hospital, but I also created, you should remember Tom Peters in Skunk Works. And when I came to the hospital and I said, there's all these things we need to do. And then you start going, well, my CEO said to me, you're just like one of that skunk work guy. And I went, I have no idea what you just said, but doesn't sound flattering. So it was like, you don't know what no means. And my CFO used to say that to me all the time. No to you is just another way to find the yes. Go around, go under, but it doesn't stop you. And I think that's what Rev Cycle is all about. It can't stop us.
Yeah.
So I've had the privilege to work in my own company for about 25 years, in my old hospital for 200 years. 200 years, that's a long time. How about 20? 20 years. And thrilled to be with you, Bill and Gail. I haven't had the privilege to train with Gail yet, so I know we're going to have fun. This is almost, I had the most fun picking the topic. I got to pick the name of the class, and they said, make it sound like something for Olympics. And I went,
there you go.
Denials? Okay, yeah. That's what we did.
Right.
So we will be having a great title.
I love that you both have shared your knowledge and your experience with multiple organizations over the years through your own companies. And you haven't just been sort of under, one silo for, 35, 40 years. You've really shared, and I know people that have had the opportunity to work with you both have learned so much and have benefited so greatly from the work that you're doing. So let's talk about this doggone denial topic. You both have been doing this a long time. We've been talking about denials for a while, and really how problematic they can be for providers. And, I guess one of the questions that comes to mind is the approach to denials. Do you believe that providers should be focusing more on denial prevention or denial management, or is it a little bit of both?
I'll speak first. I speak a lot about first touch. And for me, the denial prevention is first touch. So we have to start at the back to manage them, get good, credible data, source of truth data that's credible to everybody we talk to, doctors and department heads. But then we need to move it to the front so that it becomes a first touch prevention plan. Some of the stuff we find at the back end with denials, it really is in-house. We need to clean up some stuff in our own backyard. And then we separate the things that are the payers. So it's important that we don't just blame it all on the payers because they could carry a lot. But on the other hand, I always like prevention, even with the payers. I always say to the folks, when you say you want an appeal, tell me how you want it so that we can take that and incorporate it back to first touch and change the way we ask for inpatients, change the way we ask for a surgery that they're saying is not medically necessary, change the way we talk to a payer. A lot of work I do with UR nurses or case management RNs, and I try to teach them how to do first touch with a payer. Because when we change that, the back end, my joy, is to say to the back end, I want you to get bored. Please get bored. Because if we can move it to the front, we have a better chance, like contracting. We talk about their first touch. Contracting is way over here, and we're over here fighting ourselves to death, and the two shall not speak.
Yeah,
so we do a lot of that too.
Good. Gail, thoughts on that?
I think there obviously has to be a lot of communication between managed care and revenue cycle. I completely agree with Day, though. All of this stuff needs to be on the front end. The whole concept of pre-service financial clearance. There's so much to be done there for scheduled stuff. We're never going to be able to control what just shows up. That's the way the world works. And we need, however, to control everything in as clear and clean a way as we can from the very beginning, as she says, first touch on anything scheduled. I just feel like case management, utilization management, these folks get blamed for a lot of things, quite frankly, that they shouldn't, because today's point, there are things that we need to do better. And knowing payer policy from the payer's perspective, medical policy, what they think is medically necessary. I've said to doctors for a long time, no payer's trying to tell you how to do medicine, but they are telling you what they'll pay for.
Yeah,
absolutely.
Yeah,
Very
absolutely. Good. Well, that's a great point. Yeah, it really is. And I think there's power in information, right? Power in data. It's important to get your arms around your data and really, whether you're breaking it down by payer, type of service, whatever it might be, and really come back to them with the information that'll hold them accountable. It's one thing to say you have an issue, but if you can lay it out and really show, this is what's represented in the last 30 days, for example, I really believe that speaks loudly to and helps you hold them accountable.
I think too, Bill, that it's very important for our staff to be intellectually curious. They need to be suspicious. If you go into a payer portal and it says, oh, no authorization is required, don't believe it. Yeah. Go out there and make sure. Sometimes you may have to dig around in the payer policy to find out. But I think that's what we do sometimes is we just let the payer give us the answer when we need to dig for an answer that makes good sense to us.
Right.
It's like when someone says, oh, they say it's not necessary to have an MRI authorized. That can't be right. It just can't be right.
No.
So you have to have that intellectual curiosity and that kind of little suspicious detective nature to really dig into this stuff and get the right solution, get the right answer.
I didn't have this question written out there, but I'm thinking about it as we're talking. As a revenue cycle department, what interaction do you have with some of the other departments in the hospital? Who's it good to reach out to? Contract management, whoever, just to have some conversations and address some of these issues that keep coming up. Is that important?
When we talk about the punishment of denials, it means we don't need to keep secrets. As a hospital, the rev cycle touches everybody. And the more we can teach how it works that way, I love what Gail's saying here. I love the fact too, that when we learn something from a payer, and when, like I said, when we win appeals, why did we win? When we're being denied as for the Medicare Advantage, I'll just use inpatients, Medicare Advantage plans as not medically necessary, whatever that means to them. If we use the Medicare law, then we change the way we send things to the payer because they told us why they denied us. If we just know the words, complex medical factors. Okay, what does that mean? You go to an RN, you go to a doctor, you go to your documentation. It doesn't even make sense. So if we just take a reg and try to shove it down people's throat, they don't know what we're talking about. So it's important, Rev Cycle, remember who your audience is. So Bill, the answer is we touch everybody in the world that we see mostly with denials, like, Gail's saying, no prior auth required. We did it as an action team in a hospital I was just in for 6 months, and we tried to track every one of those by payer. And then you go back to the payer and you'll say, it says in the portal, no prior auth. So we developed a policy that we would try to get a prior auth. We would just we would just ask for it anyway. And every time they did it, they were not given a prior auth.
Yeah.
Every time they tried, every time with 3 different payers, they would just say, there's no prior auth required. Then the remittance comes back, prior auth required, you're denied.
Yeah.
That kind of vicious circle just defeats people. It just defeats them. So we have to say, as a revenue cycle leader, how are we looking at this different? Now, contracting, come on, we got to talk. We got to talk. This is abuse of the contract. So what team do we need to have? Boy, if Rev Cycle isn't joined at the hip with contracting, we're not going to win anything, because all these battles, they do it, I hate to say this, in every contract, there's that section that says, we will make changes per our webpage and you will follow whatever we say. Yeah. Can you imagine signing a contract for a car and they can just come in and change anything they want at any time?
That's right.
We've done that with these payers' contracts.
Right.
And we're surprised when they start doing that to us. So
yeah,
you got to know who your audience is, know what the issue is, and how to kind of dummy it down so they understand what we're saying.
Gail, thoughts on that?
Yes, that whole concept of contracting and giving them the liberty to unilaterally change the payer relations manual, the provider manual, and the rules. The contracts say they can do that. Now, they have requirements on how they notify us. So what I say to clients is, every time they change something in that provider manual that isn't specifically something that was in your contract, you need to dispute that as a contract violation. We've got to get stronger we don't have to sue everybody, but we have to get stronger, in my opinion, in coming back to them with specific things that they're doing that are impacting our net revenue. And just like Aetna and this unilateral decision that they will decide the level of care, they're going to take all your inpatients and then tell you what they'll pay. They made that decision on their own.
Yeah,
right.
They didn't, and I don't know, I'm speaking from Florida, but I imagine knowing Aetna, it's everywhere.
Yeah.
And they thought they made it easier on us. So, oh yeah, we approve your inpatients, that's fine. Well, that's not the same thing as we approve your inpatients and we'll pay you what you believe you're entitled to. Yeah. They are just doing their own leveling. It's like when the ED did it, they implemented a bunch of ED levels that left us with no alternatives except to dispute them. So we have to be clear about what to dispute as well.
Right. Yeah. Ladies, as we wrap this up, just real quick, short and sweet, any advice you would give to revenue cycle leaders, not just around denials, but just revenue cycle leaders that are out there? I mean, we need to come together as a community. We need to support each other. Any advice you want folks to think about and take away?
Well, first of all, I would always tell you to network through HFMA. Every time I'm at the privilege to speak, I'm always reminding them the strength of your HFMA chapters. You do not have to go these battles alone. Everybody has a contract with Blue Cross, for goodness sakes. Go talk to each other and talk about how you come together to be one voice. I work a ton with critical access hospitals. I work a ton with rural small hospitals, and they're out there fighting the fight themselves. And I said to them, do you really think you're going to get heard? I mean, I don't want to be hurtful, but you're kind of just this little tiny thing. Yeah. But there sits your HFMA chapter. There sits all these hospitals in our states. So I would say Rev Cycle leaders, reach out and start gathering data from like sizes, like hospital, but use HFMA. I'm a disciple forever.
Wonderful. Gail?
I believe that in the strength in numbers as well. HFMA Hospital Association.
Yep.
You have to pull together on these problems that are universal for all of us and fight that battle not alone. Even if you're big, don't fight it alone.
That's
If you're
right.
small, it's really hard to fight it alone. The other thing is, for God's sake, keep your sense of humor
Sense of
and
humor.
don't give up. That's
Yeah,
my big advice.
right.
Keep your sense of humor and don't give up.
Yeah, yeah. You both
Yeah,
have
Bill,
been.
how many times do we just say the rev cycle leader just needs a hug? How many times do we say that? You
That's
just
right.
need to, you know,
That's
some of
right.
this, I bet in this class, Gail, we're going to have some of these people, you just want to go up and hug them. Oh my gosh,
Yeah.
the pain is so obvious that they're
Yep.
going through. And
Yep.
what is the answer? How about just a hug? Because that might be all you're going to get today.
Right. You both have been very supportive of business partners too. And so I think when you talk about collaboration, I think, reach out, utilize the business partners that are out there that can help you too. So
True.
that's great.
Yes.
Ladies, thank you for all you do. We look forward to seeing you in Greenville. Your session again, Punishing Denials While Going for Gold, will be on Thursday, February the 18th at 1:30. We will see you then. USA,
All right.
USA.
Bye, guys.
Thanks a
Bye,
lot.
Bill.
Thank
Thanks
you.
again. Bye, Gail. See you
Thanks.
soon.
Bye.
See you soon. Bye bye.
Bye.